Scott Brown's Otology, Audiovestibular Medicine, Chapter 46, Anatomy and Embryology of the External and Middle Ear. Today we are going to deal about the introduction and the external ear. Introduction. The ear functions as an early warning system by detecting and locating potential threatening environmental sounds. It is crucial for survival by accurately and rapidly detecting head movements so that the eyes can stay fixed on the prey or predator. The ear plays a major part in the balancing system, giving important information about sudden changes in the environment, both external and self, to avoid falls and injury. In addition, in many animals and especially in humans, the ear form a major part of communication system. A three-dimensional appreciation of the complex temporal bone anatomy is crucial for the understanding of both pathophysiology and surgery of the ear. Traditionally, the microscope has been used as main tool to examine and operate on the temporal bone. In more recent years, endoscopic techniques have enhanced the visualization and magnification of vistas previously unseen. Both conventional and convenience have separated the ear into three parts: external, middle, and internal for descriptive purposes. The structure of the internal ear is described in detail in Chapter 47, Anatomy of the Cochlear and Vestibular System, relating ultrastructure to function. This chapter deals with the external ear and the adult middle ear cleft, including the mastoid cell system and escutcheon tube. Finally, the embryology of the ear and subsequent development of temporal bone, external ear, and mastoid process are outlined. The external ear, the auricle. The auricle of pinna projects at variable angle from the side of the head and has some function in collecting sound. The lateral surface of the auricle has characteristic prominences and depressions, which are different in every individual, even identical twins. This unique pattern is comparable to fingerprints and can allow identification of persons on the physiognomy of their auricles. The curved rim is the helix, which often has a small prominence, Darwin's tubercle, at its posterior superior aspect. Anterior to and parallel with the helix is the another prominence, the antihelix. Superiorly, this divides into two crura, between which the triangular fossa, the scaphoid, lies above the superior of the two crura. In the front of the antihelix, the partly encircled by it is a concha. This is divided into two portions by the descending limb of the anterior superior portion of the helix, known as the crus of the helix, which rests just above the external auditory meatus. The smaller superior portion is the sympa conchae and is the direct lateral relation to the suprameatal triangle of the temporal bone. The larger inferior portion is known as the cavum conchae. Below the crest of the helix and overlapping the external auditory meatus is the tragus, which is a small blunt triangular prominence pointing posteriorly. Opposite the tragus at the inferior limit of the antihelix is the antitragus. The intertragic notch separates the tragus from the antitragus. The lobule lies below the antitragus and is soft, being composed of fibrous and adipose tissue. The medial cranial surface of the auricle has elevations corresponding to depressions on the lateral surface and possesses corresponding names, for example, the amentia conchae. The body of the auricle is formed by elastic fibrocartilage and is a continuous plate except for a narrow gap between the tragus and the anterior crest of the helix, where it is separated by a dense fibrous tissue band. This gap is the site for an endoral incision, which, properly performed, should not damage cartilage or its perichondrium, and which, by splitting the soft tissue ring surrounding the bony ear canal, allows wide exposure of the deeper parts. The cartilage extends about 8 mm down the ear canal to form its lateral third. The cartilage of the auricle is covered with perichondrium, from which it derives its supply of nutrients, as cartilage itself is avascular. Stripping the perichondrium from the cartilage, as occurs following injuries that cause hematoma, can lead to a cartilage necrosis with crippled up boxer's ear. The skin of the pinna is thin and closely attached to the perichondrium on the lateral surface. On the medial cranial surface, there is a definite subdermal adipose layer that allows dissection through the pinnaplasty surgery. The skin of the auricle is covered with fine hairs, and most noticeably in the concha and the scaphoid fossa, there are sebaceous glands opening into the root canals of these hairs. On the tragus and intertragic notch course, thick hairs may develop in middle-aged and older male. The cartilage of the auricle is connected to the temporal bone by two extrinsic ligaments. The anterior ligament runs from the tragus and from a cartilaginous spine on the anterior rim of the crest of the helix to the root of the zygomatic arch. A separate posterior ligament runs from the medial surface of the concha to the lateral surface of the mastoid prominence. Intrinsic ligaments connect various parts of the cartilaginous auricle that between helix and tragus has already been described, and another runs from the antihelix to the posterior inferior portion of the helix. Extrinsic and intrinsic muscles are attached to the perichondrium of the cartilage. Temporal and posterior auricular branches of the facial nerve supply the extrinsic muscles, and while being functionally unimportant, they give rise to the postauricular myogenic response following appropriate auditory stimulation. There are three extrinsic muscles: auricularis anterior, superior, and posterior, the last being supplied by the posterior auricular branch of the facial nerve. All three radiate out from the auricle to insert into the epicranial aponeurosis. The intrinsic muscles, 6 in number, are small, inconsistent, and without useful function. Arterial branches of the external carotid supply the auricle. The posterior auricle appears to be the dominant artery and supplies the medial surface, except the lobule, the concha, the middle and lower portions of the helix and lower part of the antihelix. The anterior auricle branches of the superficial temporal supply the upper portions of the helix, antihelix, triangular fossa, tragus and lobule. The superior auricular artery has a constant course and connects the superior temporal artery and the posterior auricular artery network. This branch can provide a reliable vascular pedicle for the retroauricular flaps. A small auricular branch from the occipital artery may assist the posterior auricular in supplying the medial surface. Both cranial branches, branchial nerves, and somatic cervical nerves supply the auricle. Their distribution is heterogeneous and the overlap may be extensive. However, the greater auricular nerve prevails on the lateral and medial surfaces. The essential features are described in table 46.1. Figure 46.1, right auricle. This is the scaphoid fossa, auricular tubercle, helix, cavum conchae, antitragus, tragus, lobule, antihelix, cymba conchae, triangular fossa. Table 46.1, sensory innervation of the auricle, nerve derivation, regional supply, greater auricular, cervical plexus C2, C3, medial surface and posterior portion of the lateral surface, lesser occipital, cervical plexus C2, C3, superior portion of medial surface, auricular, vagus 10, concha and antihelix, some supply medial surface, ementia conchae, auricular temporal, VC, 5C, mandibular, tragus, crus of helix and adjacent helix. Facial nerve 7, probably supplies small region in the root of concha. The lymphatic drainage from the posterior surface is to the lymph nodes at the mastoid tip, from the tragus and the upper part of the anterior surface of the preauricular nodes, and from the rest of the auricle to the upper deep cervical nodes. The external auditory canal. The external auditory canal extends from the concha of the auricle to the tympanic membrane and is approximately 2.5 cm long. The supporting framework of the canal walls is cartilagine in the lateral 1/3 and bony in the medial 2/3. The diameter of the canal greatly between individuals and between different races. In adults, the cartilaginous portion runs inwards, slightly downwards, and forwards. The canal is straightened, therefore, by gently moving the auricle upwards and backwards to counteract the direction of the cartilaginous portion. In the neonate, there is visually no bony external meatus as the tympanic bone is not yet developed, and the tympanic membrane is more horizontally placed so that the auricle must be gently drawn downwards and backwards for the best view of the tympanic membrane. In the adults, the lateral cartilaginous portion is about 8 mm long and is continuous with the auricular cartilage. The medial border of the meatal cartilage is attached to the rim of the bony canal by fibrous bands. There are two horizontal fissures described by Santorini that lie anterior inferiorly in the cartilaginous portion that possibly increase flexibility but allows passage of infection or tumor into the parotid gland. The bony canal wall is about 1.6 millimeter long and is narrower than the cartilaginous portion and itself becomes smaller closer to the tympanic membrane. The medial end of the bony canal is marked by a groove, the tympanic sulcus, which is absent superiorly. Although the tympanic bone makes up the greatest part of the canal and also carries the sulcus, the squamous part forms the roof. Therefore, there are two suture lines in the canal wall with the tympanosquamous anteriorly and tympanomastoid posteriorly. These suture lines may be more or less developed. They project into the canal with overlying closely adherent skin, which can make raising an intact tympanomeatal flap a challenge. The tympanomastoid suture is a complex suture line between the anterior wall of the mastoid process, a portion of the squamous bone, and the tympanic bone. Apart from these intrusions into the canal, there are two constrictions one at the junction of the cartilaginous and bony portion and the other, the isthmus 5 mm from the tympanic membrane, where a prominence of the anterior canal wall reduces the diameter. Deep to the isthmus, the anterior inferior portion of the canal dips forwards, forming a wedge shaped anterior recess between the tympanic membrane and the canal. This recess can be a difficult spot for access either in the clinic or at surgery. The external canal is linked with keratinizing stratified squamous epithelium, which lacks the rete pegs and skin appendages in the thin skin of the bony canal. The body skin normally grows directly from the basal layer towards the surface where it sheds into the surrounding. Excess proliferation in the scalp trapped by the hair is dandruff. If this pattern of growth were to occur in the external ear canal, the canal will soon be filled with desquamated skin. Instead of maturation taking place directly towards the surface, there is outward oblique growth of the epidermis of the canal skin and pars flaccida so that the surface layer effectively migrates towards the external opening of the canal. The normal rate of migration is about 1.1 millimeter per day. Although this range is hugely variable, and in some conditions there is complete failure of migration with a consequent buildup of shed keratin in the ear canal. It has been postulated that patients who are prone to cerumen impaction may lack a keratinocyte attachment destroying substance KADs based on this observation that they have much longer sheets of desquamated keratin which are in continuity with the stratum corneum when compared to the patients with no issue. The skin of the pars tensa has a different deviation from that of the deep canal, and cell divisions occur randomly within the layers of basal cells. The effect of this in circular sheet with the handle of the malleus forming a central boundary extending halfway down the membrane is to create outward mass migration of the skin of pars tensa. Ink dots applied to the surface have an outward pattern of movement. However, if a hole is made in the tympanic membrane and a graft laid underneath the membrane and underlay graft, migration of the skin from the outer edge of the perforation is directed centrally to cover the graft. This occurs because the boundary conditions have altered and fortunately provides the basis for healing of grafts and for the reepithelialization of the mastoid cavities. Even a small piece of past tensa skin has this ability and is so a precious material and needs to be preserved during ear surgery if a bare area needs covering. However, the property of canal skin to migrate can also bring problems with formation of cholesteatoma if the skin becomes displaced into the middle ear cleft. At the outer limits of the ear canal are some short hairs that project towards the opening of the canal. There are fine vellus hairs and large terminal hairs called the trachea, Greek word for goat, which tend to be more prominent in males, in which they are a second sexual characteristics. These hairs are oriented with their tips laterally and increase in number and length from the bony cartilaginous junction laterally, so helping to prevent the entrance of foreign bodies. In the skin of the cartilaginous canal are clusters of cerumen and sebaceous glands. The ceruminous glands are modified apocrine sweat glands that open into the root of the canal of the hair follicles and produce a watery white secretion that slowly darkens, turning into semi solid and sticky as it dries. Since these glands are apocrine sweat glands, they respond to many stimuli such as adrenergic drugs, fever, and emotion, which, along the direct mechanical stimulation, can all produce an increase or altered secretion. The sebaceous gland produce an oily material sebum from the breakdown of their fat containing cells, which is usually excreted into the root canals of the hair follicles. The mixture of these chromated cells, cerumen and sebum, forms wax. Human earwax is Mendelian character trait consisting of wet wax and wet and dry forms. Dry wax lacking cerumen is yellowish and gray and brittle, while wet wax is brownish and sticky. The wet phenotype is dominant over the dry type and is frequently seen in populations of European and African origins. East Asian shows dry phenotype, and there are intermediate frequencies among the Native American and Inuit of Asian ancestry. A single nucleotide polymorphism in the ABCC11 gene is responsible for the determination of earwax type, with the AA genotype corresponding to dry wax and GA and GG to wet wax. There is distribution with regard to specific antibacterial activity of cerumen in vitro studies. However, the areas of skin that take part in cerumen production have all components of an active local immune system and probably protect the canal by an antibody mediated local immune response. Wax is not usually found in deep ear canal, and a lump of wax overlying the upper portion of the tympanic membrane, pars flaccida or attic region, is rarely true wax, but is nearly always associated with an underlying cholesteatoma, as it is in fact dried up oxidized keratin. The sense of old age, beware the attic wax, is still just as true as it was in the past. The arterial supply of the external meatus is derived from the branches of the external carotid. The auricular branches of the superficial temporal artery supply the roof and anterior portion of the canal. The deep auricular branch of the first part of the maxillary artery rises in the parotid gland behind the temporomandibular joint, pierces the cartilage or bone from of the external meatus, and supplies the anterior meatal wall skin and the epithelium of the outer surface of the tympanic membrane. Finally, auricular branches of the posterior auricular artery pierce the cartilage of the auricle and supply the posterior portions of the canal. The veins drain into the external jugular vein, the maxillary veins, and pterygoid plexus. The lymphatic drainage follows that of the auricle. The external auditory canal receives its sensory innervation from trigeminal, facial, glossopharyngeal, and vagus nerves. Frequently, patients can cough when undergoing microsuction of the ear canal, which is caused by stimulation of the vagus nerve via Arnold's nerve, its auricular branch. The relationship of the external canal are depicted in figure 46.2, and coronal sections through the external canal and middle ear are shown in figure 46.3. Figure 46.2, relationship of the right external auditory canal. Superiorly, middle cranial fossa; anteriorly, temporomandibular joint; superficial temporal artery and vein; auricular temporal nerve; parotid gland; pre-auricular lymph node. Outside world, lateral; inferiorly, jugular bulb; carotid; facial nerve; styloid process; parotid gland; digastric muscle. Posteriorly, mastoid. Medially, middle ear. Figure 46.3a, diagram of the cross section of the external canal and middle ear at the level of the malleus handle. B is a photomicrograph of a more posterior coronal section, including malleus and the stapes. This is the lateral malleolar fold. This is the superior ligament of malleus. Outer attic wall or scutum. Pars flaccida, lateral process of malleus. Umbo, pars tensa, tympanic sulcus and annulus. Promontory, processus cochleariformis. Facial nerve, chorda tympani, superior ligament of malleus, and middle cranial fossa. Thank you.